thank you for attending this evening's town hall where we will be having a discussion about coronavirus. This evening will be broken up into 3 different parts. So the first part will be an update on everything medical that we know about coronavirus. The second portion of the talk will be about what Medical City and HCA in general are doing to help us deal with this. And then the final portion of this evening's talk will be open for questions and answers. So with regards to the first part of this talk, I would like to introduce our own Dr. Bonnie Rowett, who did her medical training at SUNY Buffalo and then went over to St. Louis where she did her residency and fellowship at Barnes Jewish Hospital. She has been on staff here since 1997, and we're very fortunate and lucky to have her present to us today and give us her clinical judgment always.
Thank you everybody for coming. I'm calling this the world's largest hand hygiene exercise, this epidemic that's going on. So there's actually 3 pandemics going on right now. One is influenza, seasonal influenza, which has had over 3,000 hospitalizations in this country, 18,000 deaths, and 32 million cases. And I bring that up as a perspective. Did anyone hear those statistics and head to Costco for toilet paper? And so I just want to kind of keep that in mind. This is still ongoing. We still have pandemic flu levels in the United States. In Dallas County, it's over 15%. Usually we consider epidemic levels when it's over 10% of the tested samples are positive. So we're still in the midst of a flu epidemic. We also have COVID-19. Now just a little bit of an explanation. So taxonomy-wise, this is called SARS-CoV-2 virus. It's kind of like the Staph aureus genus species of the virus. Why they decided to call it that, I'm a little confused. But anyway, the disease process is called COVID-19. And the World Health Organization spent a lot of time laboring over this because you do not want to curse one city or country or whatever in the world for being responsible for some dread illness. And they've actually done this before. Ebola, for example, is named after a river, not a country or a region or whatever. So anyway, with COVID-19 is our disease process. So that's our second epidemic. Right now, the current stats are 118,000 cases worldwide, 42,062 deaths. It's present in 115 countries. And here's the really important part that gets lost in the media message. 64,391 people have recovered from COVID-19. So the third pandemic that I'm going to talk about, and one of the reasons I'm glad that we're all here to try to get the information out to our family and patients and friends and everybody else, is the fear and ignorance pandemic. And of all the 3, this is probably one of the more difficult to combat. So one of the things I wanted to just give a little historical background on this and kind of tell us where we're at with some of the research and everything. And if some of this isn't making sense, feel free to break in with questions. So a lot of the term that we use in infectious disease ecology is called spillover. That refers to a lot of the ways that some of our pandemics in the 20th and 21st century have occurred. What that means is pathogens that show up in another species adapt themselves to be able to infect humans. Sometimes that's a dead end, like some of the avian flu strains that have been able to get to people in small amounts but really never caught on as far as person-to-person transmission. Sometimes it's limited dead ends, such as Ebola epidemics have been coming in waves. And some of the other more common ones, influenza, for example, is essentially a zoonosis. It came from various animals, both birds, swine, etc. Ebola is another example. The HIV virus, heard of that one? Coronavirus. And just as an aside, I have to have a little bit of a bright note. The Ebola epidemic in the Democratic Republic of Congo is finally getting under control. That's totally slipped from the news, but that's important news. So back in the 1960s, researchers discovered this really cool cause of the common cold called coronaviruses. So these are, these have been around for a while. There's 4 of them, 2 alpha, 2 beta, that cause common cold symptoms in humans. So coronaviruses are not new. So one of the things to kind of keep in mind about viruses, coronaviruses are a positive RNA virus They don't correct themselves very well, which means they're subject to mutations. So one of the quotes I thought was pretty cool. So the human genome took 8 million years to evolve itself by 1%. The RNA viruses can evolve themselves by 1% in that number of days. So this is not a rare thing that we have RNA viruses such as HIV and now coronavirus plaguing us and causing lots of mischief. So animal RNA viruses can get into humans. We don't always understand directly what that is. Some of the global pressures that allow this to happen, population growth is a major factor, habitat loss, travel, people being able to get into areas and have animals for snacks that they didn't used to be able to even get at. All these are major factors and things that have contributed to these recent pandemics. So back in 2002, 2003, we had SARS. And this started in southern China and spread to many countries around the world, had a large impact on Korea. And it was a coronavirus. And it was the first time a coronavirus had been such a bad actor, very high mortality rate. The thing about it is when people were actually at their peak of symptomatic whatever, that's when they'd be shedding virus. Very few asymptomatic carriers, and good public health and some element of luck got that virus under control. There was a virus vaccine on a shelf that never actually got developed. After the SARS epidemic and Ebola and MERS, which hit in 2012, which is another coronavirus, we had a group of people called the PREDICT group that was developed after the Ebola epidemic in 2014. And unfortunately, what this did was a group of researchers, epidemiologists, public health authorities, safety, emergency planning, people that interface with all the branches of our federal government. One of our presidents, unfortunately, his first acts in office was to disband and fire all these people. Some of the things they're working on is general antivirals, which we don't, of course, have now, and vaccination issues. And so I think it's just a kind of a word of warning that when COVID-19 is under control, and it will be, we need to not forget what we've learned from the last now 3 coronavirus outbreaks as far as preparedness and research funding. They can't really be replaced. So coronavirus, incidentally, is not named for the beer. Beer sales are apparently off 38% for that company, so, you know. Where does the coronavirus do its dirty work? The corona is named after like the corona on the sun, and there's little spike proteins that are pretty cool, and they bind to something called the angiotensin converting enzyme 2 receptors in the lower respiratory epithelium. Now, China has taken a major publicity hit with this epidemic, but one of the things I'm here to say is that the researchers and virologists there have done awesome work, and have been doing awesome work really since the early 2000s when coronaviruses first hit the scene. There are a lot of researchers that went out and were going into bat guano-infested caves and studying animal coronaviruses, because we know that all 3 of these viruses probably originated in bats. And we knew that there was a coronavirus developed or discovered in 2013 in bats. And this is the one that's the most similar in homology to the coronavirus, the SARS-CoV-2. So I want to make sure everybody in this room leaves this with conviction. This was not a lab accident. This was not biomedically engineered. Because frankly, if you're going to plant a coronavirus that would have done things, you would have picked a better virus. Because just looking at the sequence of this, there's something called a binding domain, which had 6 amino acids. If you would have wanted to be a lot like SARS, this one isn't. But we've got a couple of prolines upstream that glycosylated and protect the virus and all these other things. This was Mother Nature. This was not anything human doing this. And the internet rumors just continue to not be squelched, which is really kind of a shame. So please be part of the solution and get that word out. By the way, all the cardiologists in the room, angiotensin converting enzyme inhibitors do not work on this. Good thought, though. Good thought. So the receptor binding domain we talked about. So bats and coronaviruses, the bats coexist with their coronaviruses. They're enteric in bats. They're not respiratory pathogens. So another thing I want to do as far as we have to be really careful about, sort of stereotypes and whatever. People didn't get this from eating bats. There was one video that kind of was making its rounds on the internet of some woman munching down in a bat. It was actually from Malaysia. And probably, we don't know exactly how this virus was transmitted from bats to humans and whether there's an intermediary host. But it was probably more likely to be some sort of respiratory communication rather than what they had for dinner. I'm sure all of you are aware of how this The biggest cluster of cases started at the Wuhan fish market. However, there were coronavirus cases prior to that outbreak, and that's important to know. So this virus has probably been around at least a month before those known cases. So there were some intermediary hosts in SARS. There was something called a civet cat, which looks like a long, skinny raccoon kind of creature. And for whatever reason, these were felt to be delicacies to eat. And in MERS, it was camels that we were kind of cohabitating with. It was an intermediary host. We don't know about with the CoV-2. Possibly there's these critters called pangolins. I personally don't think this is going to wind up being it because they're not native to China. They're cool critters that look kind of like anteaters, but they're not phylogenetically related. And they eat them for scales and all this other stuff. But they are harbingers of coronaviruses that are somewhat similar to one in humans. So regulatory efforts in China about these wet markets, as they're called, started after the SARS epidemic because it was recognized this is a problem. We can't just have all this unregulated stuff going on. And it worked for a while, but the markets were very popular. And then, of course, after SARS went away, the enthusiasm for regulatory issues went away because they're very profitable. And these are considered delicacies in some of these animals and everything else. So that probably caused some problems. The virus was sequenced amazingly quickly once it was identified. Some of the problem is the CDC China is actually a dual regulatory agency and research institution. So it's kind of like our CDC, public health-wise, and it's a research institution. The problem with that is they published a series of cases in the New England Journal documenting human-to-human transmission before they told the Chinese public that that was a possible thing. So while they've done amazing quarantine efforts since that time, that was a little bit of a misstep, and we don't know, what would have happened if we could have gotten on it sooner. Coulda, shoulda, woulda. But again, I want to give a shout out for the phenomenal work of the virologists who have been trying to get the word out. So the incubation period on CoV-2 seems to be about 2 to 5 days, and it's kind of holding steady with more information that we've gotten. The longest, is about 14 days. There have been a couple outliers that are, some of those are actually questionable based on when the person was supposedly exposed. But 14 days still seems to be covering about 95%, or sorry, 99 point whatever percent of cases. Excuse me. Usually by day 11, about 98% of people will have developed symptoms. So the big question is, how bad is it, and how does it compare to flu? Those are questions we ask a lot. So in China, Ghana, and Singapore, they're actively doing surveillance. And so that means they're testing people who are not symptomatic. So we're gradually getting this information. And virtually everything I talk about coronavirus tonight is probably going to be subject to, could change without notice as more information becomes available. And I have to just put that out there. So probably less than 1% of the cases are asymptomatic in adults, in contrast with SARS. But we just don't know. That's a very movable number. Most people develop symptoms within a couple days. Now the problem is, what does asymptomatic mean? Well, maybe their back was aching more than usual, and only in retrospect did they realize that they weren't really at their usual state of health. And that's why that's kind of the moving number. But nonetheless, if you're not seriously ill enough to seek care, you could still be shedding virus in the community and not know it. So we really need more of the seroprevalence studies. They're just now getting underway to really be able to tell what's going on with that. So it appears that the transmissibility of COVID is probably worse than flu, but exactly how much worse we don't know. We talk about something called the R0 number. What that is if an infected person, how many people do they spread the virus to? In influenza, it's about 1.3 people. In COVID, it's anywhere between 2.2 and 3.5. And again, that denominator, is like some of the changes we get more information. So case fatality rates are holding pretty steady so far, but again, I think this number is probably going to be a bit of an overestimate. It's 2.3% right now versus influenza, which is about less than 1%. Perspective, though, it's still bad. The influenza epidemic of 1918 had a case fatality rate of 0.5 and 1%, for perspective. And it took out probably 50 million people worldwide. So, low fatality rates and common illnesses are still kind of a problem. So how does it spread? This is primarily a respiratory droplet spread on this pathogen. With droplets, we use terms, you see the signs up around the hospital, droplet versus airborne. Droplets are the fairly large particles that have moisture in them that come from people's respiratory trees. And if you're 6 feet away, what happens is you get cough, 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 boom, 6 feet away, the droplets are out. So one of the things we talk about with preventing coronavirus is social distancing is the fancy term. It means get away from other people. It works. So that is the most common, and it's been substantiated now with more case studies we get in. Airborne precautions is of a concern, And that's why we still recommend N95 masks, negative pressure rooms when we have the luxury of having them, when people come in with a possible coronavirus. But the vast majority of this transmission is probably going to be droplet transmission. What does airborne mean? If you're doing something like intubating a patient or large procedures like a bronchoscopy that could potentially break up particles and make them smaller to get down into our lower respiratory, but more importantly, survive on air currents, and that's what we talk about as being airborne. So how else is it transmitted? Probably, it's an interesting thing with the media where they distort the small number rare thing as being the big deal. So probably everybody's heard about the plumbing fiasco in Hong Kong with the coronavirus being fecally transmitted. So those little things called P-traps, not because of number one, but because of the shape of the trap that sit under your sinks, those are basically locked to keep out gas and things from backwashing into your plumbing. For whatever reason, this one apartment complex took out all the P-traps and they basically had maladaptive plumbing, which I don't think is very common in the United States. In any event, it's kind of like an aerosolization of whatever was in the feces. Now, this is gross, but we swallow our mucus every day. And so I expect if you had a respiratory infection, you're going to wind up with virus in your stool because you're swallowing it. So what does that mean as far as infectivity? One of the things that's not correlating very well, about 15% of people with COVID or the SARS-2 actually have GI symptoms, but it doesn't correlate necessarily with fecal transmission. So how much that is playing a role, we don't know. There's an article in Gastroenterology that, oh no, the GI tract's got ACE2 receptors too. That's interesting, we don't know what it means yet. So potential, yes, we could have fecals shed with this, but that's also a heck of a lot easier to avoid than respiratory stuff with hand washing and closing the toilet lid. So what about fomites and how much do we get infected from other things in the environment, not just people? So one of the primary spreads of all the respiratory viruses, RSV, influenza, metapneumovirus, you name it, is touching a surface, finger to nose, finger to eye, finger to whatever part of your face. So certainly fomites are going to be a bit of an issue, but again it gets back to hand to whatever. So the question that's come up a lot, and we don't again have a good, it's not a simple answer. How long does it survive on surfaces? Great question. They've studied a bunch of the coronaviruses, including COVID-19, and it does survive on surfaces under perfect conditions. So if you get like a metal plate and a glass plate and a plastic plate, it could last up to 9 days, but you have to have the absolute optimal conditions of temperature, humidity, keeping it away from ultraviolet light, and all these things that mean you do not have to worry about your Amazon package from China. So, have at it. Internet shop with impunity. Big deal of that. The other really good news is you can kill this virus. Unlike Ebola, where it was very, very concerning as far as the cleanup after an Ebola patient, it's killable by all our standard commercial disinfectants that we use in the hospital and the ones that you use in your home. They've studied high alcohol content things, hydrogen peroxide, sodium hypochlorite, which is basically bleach. Benzalkoniums are ones that you use in your fantastic cleaner and everything else. Those don't work quite as well, but I'm sure they do a perfectly fine job for stuff around the house. So as far as one of the myths I wanted to dispel here tonight too is children don't get infected. Actually not true. Children get infected in similar rates to adults. The Shenzhen, I can't pronounce it, sorry, city in China did a study, and children are as likely as adults to become infected, but they're much less likely to be symptomatic, and the death rates, fortunately, are much, much less. So there's an increase in fatality rate as you go up deciles of life, which is kind of depressing for some of those little farts in the audience. It's up to 15% in patients over the age of 70. But again, that means 85% of them are going to be surviving. Try to have the glass half full here. One of the things that was interesting early on in the epidemic in Wuhan was the role of tobacco use. Because initially, in one of the first case studies that they did, or groups of cases, there's this disproportionate men versus women. But then they looked at the data, and it's because men in China have a much higher incidence of smoking than women do. So it's positive, it's a plausible theory that may be one of the reasons for poorer outcomes. So, and then of course the question comes up, what about Fluffy? So this has been way overplayed. Do not make your dog wear an N95 mask. There was one case where they discovered virus in someone's Pomeranian who was asymptomatic in rare amounts. What does this mean? I don't know. I don't think that means that Rover was infected and is going to go coughing on people. As we talked about, there is spillover, and people can spill over to their pets and with other infections. It's not impossible. However, I wouldn't spend a lot of time, worrying about that. I just really don't think that's going to be a thing. Dogs have their own set of coronaviruses, their GI viruses in dogs. I just don't think that that's going to be an issue. So how do we test for this? Testing consists of nucleic acid probes. So it's an RNA virus, as we talked about, reverse transcriptase RNA PCR testing is done. It turns out after lots of research in China and other parts of the world, nasopharyngeal testing is probably the best. If it's easier to do oral pharyngeals in a child or whatever, that's acceptable as well. We don't encourage people if they're coming in for a COVID rollout to do sputum because that's one of those that just maximizes the chances of other people in the environment getting infected. VALs work obviously, and endotracheal aspirates. There are serum tests that can be done that are not done commercially. In the cases from the CDC, if they're meeting person under investigation criteria, we are sending serum, and it goes to the health department onto the CDC. So one of the things to emphasize, specimen collection is key, and this is important for how we deal with the outpatient coronavirus cases as well. It has to be, to the best results, it has to be a posterior nasopharynx. And I never thought I'd spend so much time talking about sticking stuff up people's noses, but it really is important. We have issues with people just do anterior nasal swabs, missing things. And there's been moves in other countries to do home test kits. I will be the first to admit, I'm not going to do a home test kit because I don't think I can jam something into my posterior nasopharynx without really not wanting to do that. So that's an issue. And it also makes it tricky because you're not just going to send people to their LabCorp draw station and have a local phlebotomist check for COVID. This is something that's important. There has to be care that's taken. It's a procedure that's likely to induce coughing or at least a big blot of sneeze in your face. So we have to be conscious of that, how to do mass testing and do it in a safe way. So another thing, that comment about the San Antonio resident that just started this crap storm in the media, kind of embarrassed about our state's portrayal of that. So there's cruise ship patients that are in quarantine. One woman had had 2 negative tests, was asymptomatic. They let her out. The CDC was just being attentive and finding out about this new virus, so they did another test. It was negative. Oh my gosh, you're endangering the entire population of San Antonio. We don't know that. I have an example in the unit right now of a renal transplant patient who has influenza. He was diagnosed, I think, somewhere back on the 10th of February, still shedding virus. It happens. Does that mean he's contagious? We don't know. We are not testing for intact viral, replicable particles. We're just testing for the nucleic acid. So take these things when they come on the media with a grain of salt. It's certainly going to be studied because obviously there's going to be outliers. There always are. Some people are, quote, super spreaders, where they shed the virus in large quantities for reasons that aren't entirely understood. But it's a work in progress. So, be a little bit careful when someone wants to diagnose Fluffy with coronavirus. And just, keep it in mind. So, how long do people shed? Average seems to be about 12 days, but as I said, there's a range. So that's something that we'll be looking forward to getting more information about. And how do you tell? You cannot, some of the people that were shedding virus for longer periods of time really only had mild symptoms and only had sort of upper respiratory stuff. So it doesn't, certainly in general, the sicker you are, the more virus you shed, but there's exceptions to every rule. So as I mentioned, how do we isolate these folks? When people come in, we would love for them to be in, I hate this term, AIRR, which is Airborne Infection Isolation Room. I like to call it a negative pressure room. But if we're able to, somebody's a legitimately sick person, we want to put them in a negative pressure room, which we have in our emergency room. We want to have N95 masks in use by the staff, eye protection, gowns and gloves. And PAPRs can be considered for procedures that are going to induce aerosolization, like bronchoscopies or intubations. So what about secondary attack rate? So if you've got a coronavirus in your house, how likely is it you're going to get coronavirus? Because of course that's a salient question. So in the MMWR, there's a series of cases. The CDC followed the first 10 cases off the cruise ship, and they were quarantined for 14 days. Now this is small, so again, subject to change, and as we know, it's more stuff. About 12% of people developed symptoms, but a lot of those, only 2 household members turned positive. So the symptomatic attack rate, and people that are considered close contacts, that means you've been in someone's face within 6 feet for more than 10 minutes, was 0.45%. And for family members, it's about 10.5%. So for family members, certainly they have some risk, but that's kind of good news for the person that coughs behind you in the grocery store as far as what's going to happen. So, so the role of environment in COVID testing, particularly in transmission, particularly important in the hospital. So there's a Hong Kong study that showed the environment is really not a prominent route of transmission, which is important. They did air sampling around the face of the patient, and they really didn't come up with a lot of stuff. Also, kind of going for this is more droplet than the airborne. Another study in hospital control and epidemiology was very reassuring. They had 413 healthcare workers, and I believe it was Singapore, Hong Kong, I think it was Hong Kong. 11 of them were unprotected, and none of them actually developed disease. Now, this is Hong Kong, where they've got their infection control act together big time, and they've really been able to bring their outbreak under control. But that's reassuring, and only about 7.7% of the environmental samples that they did were positive. So that's good news. In another test, another research paper from Singapore, our cleaners work. They did this, one guy was like a super spreader, had virus everywhere. They went in, did a cleaning, went back and checked, and it works. The corridor didn't have it, the antechamber didn't have it. The only thing on the PPE of the healthcare worker was a little bit on their shoes. And chances are you're not going to put your shoes to your face unless you're more into yoga than I am. So that's probably not going to be a big deal. So one of the things that's been interesting about this, from a purely scientific virology, minus the human misery, it's been really cool to watch the virology stuff. But one of the problems is there's an incredible amount of knowledge base that's been getting out there, but it's unvetted. It's been great. It's, New England Journal, JAMA, Lancet have all gotten these publications in immediately as they're pretty much written, which is really cool. The problem is there's been some missteps. There was a research paper about sequencing, for example, that some of the virologists went back and said, that's not really, you're making some leaps of conclusion here, and they really questioned it. There was an early paper on the German business group, you may have heard about that one in the news, where supposedly a woman was asymptomatic and she shed it to all these people. They kind of forgot to ask her. She went back to China, and they had all these German workers that became ill, but when they actually contacted her, were you having symptoms? Well, yeah. So again, you have to be careful about, even in the research journals, the information is out there, but it's not necessarily as peer-reviewed as it normally would be. So what does a coronavirus patient look like when they're sick, and what actually kills them, or what causes their illness? So most of the people that are coming in have symptoms within 2 to 5 days of incubation. Usually the people who are getting generally sick, they're going to be wrapped up by about day 5. Most of the people who are getting hospitalized are getting hospitalized around day 5, 6. When we really start getting bad is around day 8. And if you can make it past day 8, that's good. That's usually kind of the witching hour. And there's kind of like this continuum. It's not usually kind of back and forth. It's usually kind of a continuous sort of worsening if that's going to happen. Again, the good news is 80% of people have mild disease and never get anything past that. So radiographic findings show ARDS type pictures. They can have bilateral, interstitial, and intraalveolar infiltrates. The problem is it looks a lot like a lot of other stuff. I don't think it looks like common cases of flu unless they're secondary infection though. And they're impressive, and you can look at those scans online. So the biggest, probably most common symptom is cough, sputum production about a third. Fever, however, is not number 1. And that's something we have to kind of keep in mind as we deal with this. It was not even that common in some of the original case series that were coming out. When people become desperately ill, probably 90+% of those people have fevers. But in the earlier stages of their illness, unfortunately, it's not a reliable indicator. Our trial is about 15%. And lab abnormalities, a lot of them have lymphopenia. Some of them have leukocytosis with lymphopenia, which is a little bit weird. They'll have elevated prothrombin times, elevated LDH. ARDS and lung things tend to be what takes them out. Secondary bacterial infections have been described, and they have this whole laundry list of bacterial pathogens that have been identified in these patients. Not a predominance of like Haemophilus influenza like there was with influenza in 1918. Cardiac syndromes are pretty common as far as the people that are severely ill. They have acute coronary syndromes and they have arrhythmias, and that happens in about 18% of the patients, so it's a pretty common deal. Acute kidney injuries happen. They have gotten people back on ECMO. They've been able to get some survivors with that. And shock, just in general, about 8% of patients. So again, that's probably what we're going to be seeing, depending on the series, between 16 and 20% of patients. However, I think that denominator is skewed. I think this is what we're, they weren't seeing asymptomatic patients or less symptomatic patients in China, nor are we at this point. So what are some of the things we can do about it? Is there anything we can do to fight it? So remdesivir is an antiviral that developed for the Ebola virus and Marburg virus, and it is an adenosine nucleoside analog. It basically fakes out the RNA polymerase to stop dividing. And it didn't work very well for Ebola and Marburg, but they did, just kind of pull everything off the shelf. Oh, look, cool, it works against SARS very, very well in non-human primates. It is in clinical trials right now from the University of Nebraska. They've got about 50 centers around the world, and I believe, I've got information, I think we can get this as an investigational new drug, should we need to use it. It also is being used in China extensively. Gilead Pharmaceuticals just basically gave $2 million worth of remdesivir, which is pretty good of them because the Chinese government basically said, we got your patent, and they did it anyway, which is the right thing to do. Politics and medicine is interesting. It's PIVot IV, which is a bit of a downside, and it blocks viruses in micromolar concentrations. Another old drug they knew, again, is chloroquine, and they've actually used it in combination with remdesivir. Chloroquine, as you may recall, is a malaria drug, not used a lot anymore because of resistance, but it actually messes with the endosomal pH and keeps the virus from binding to its cell. And so it's been, shown to be pretty useful, and they've been using a fair amount of it in China. Problem is, supply problems in the United States, can't get the stuff. And I don't know if that's going to change anytime soon or not, but I've got our pharmacy people looking into that. Kaletra is an antiviral used for HIV. It is now considered probably third line. We've got better drugs, less side effects. But lopinavir, ritonavir, non-nucleoside reverse transcriptase inhibitors have been shown to be helpful. The results coming out of China are kind of meh. It's about 50-50 efficacy, but these are very small series. It also was used in combination with beta interferon, which is a very toxic drug and very expensive. And I don't know of any trials that are going on with that. Immune serum has been used in at least 11 patients, and that was, as you may recall, was used in the Ebola epidemic as well. That may be useful. There is an antiviral called favipiravir, which I don't believe is available in the United States, but they're using it pretty extensively in China. It's another nucleoside that was very, very effective against Ebola. And since some of these viral mechanisms are similar, what the virologists and scientists do, they basically pull off the shelf, and maybe it'll work for this one, and try it with that. It has, the downside of that one is it requires pretty high antiviral concentrations. And again, I don't think we can get it in the US. One of the things that's kind of cool, probably one of the reasons, and just because kids are reboundable, but one of the things that's been speculated on is why don't kids get as sick as adults? In 1918, that was not as true. There were young adults were one of the leading groups that were dying of 1918 influenza, which is pretty interesting. But one of the things that has been speculated is a lot of this lung injury looks very much like an immune maladaptive response, which is basically what ARDS is. And tocilizumab, which is an Activa, I think, is an IL-6 inhibitor. We have a stash of it for our stem cell folks. We have a CAR T protocol. So it gets this incredible cytokine storm, and it shuts it down. It's very promising work with this. And so that is another potential tool for our armamentarium. And of course, prevention, vaccines. There's over 20 vaccines that are in development right now. This is another one where, gosh, I wish we would have been keeping up on the research funding, but there's still a lot of good stuff that's going on. mRNA vaccine is the next cool thing. Moderna Therapeutics has sent a platform to the NIAID, and they're enrolling people. They're studying it, and they're going to be enrolling the trials. It's probably realistically going to be 12 to 18 months before we actually see that. But similar platforms have been used for different other viruses, which makes it cool. University of Queensland has a candidate. Sanofi has a candidate. So in the future, depending on how long this lasts and whatever, we've got potentials there, but it's only in the potential phase for right now. So as we talked about, RNA viruses change. And I want to bring that point up again, because you're going to see stuff in the media that's reported out shabbily. It's mutating. Of course it is. We know that they do this. The question is it mutating enough to mess up the vaccine developments? As it stands right now, no. Could that change if there were changes in virulence? There was some suggestion of that with the SARS epidemic. The answer is we don't know, but I would stick to reliable sources about what the significance of those mutations are. Just having a change doesn't mean it's a good thing for the virus. Some mutations are bad for the virus as far as viability and everything else. So just sort of keep that in mind when you listen to the media. So what do we do for now? We have testing available through the Dallas County Health Department, but the Dallas County Health Department is meant to be an epidemiology tool, not a mass lab. They can only run 10 to 12 specimens a day. It's not going to be a high-volume outfit. We do have access to LabCorp, which we've been sending specimens to. Quest Diagnostics has a test. ViraCorp has a test. Some of these other commercial labs, some state health departments have had their own testing in New York. For example, they came up with their own and have larger capacity. The problem, as I mentioned, though, is we don't want to have everybody who thinks they may have coronavirus coming into our emergency room to get tested. We simply can't do it. For the reasons I talked about, you really have to have the person that's sticking the nose swab in some kind of isolation and protective gear. And the bottom line is most of these people are going to be told that they're asymptomatic or minimally symptomatic to quarantine at home and keep an eye on your symptoms. You know, the exceptions that we're trying to save the hospital beds and the N95s and the negative pressure rooms for are people with comorbidities, people who are significantly ill, hypoxic, horrible CT scans, this sort of thing. So please advise your patients. The health departments, I think, are trying to get messaging about call your primary care doctors. That's great, but I feel a little bit bad for the primary care doctors because, again, you're not just going to be able to pull a swab out of your counter and get these people tested right now. This is a major thing that we need to work on, is how can we test outpatients in a safe manner, whether that's drive-by clinics, people in N95s just queuing people up, some kind of combination with telehealth where people check in remotely. We're looking for ideas. So sincerely, I'm part of the committee with the Dallas County Medical Society with emergency preparedness and stuff, and we're actively thinking through this about what that might look like and what to do. As far as the testing, the nasopharyngeal swabs are taking about 2 to 4 days to come back. If there is we have not at this time had a person under investigation, or PUI is the term, that would qualify from the CDC's, what I think is frankly overly strict criteria, especially with disease in the community and the fact that we have endemic cases here now. The travel history can't be the only thing we anchor to, and I think those things are going to have to change. And the availability of commercial labs is going to help us with that. So what to do if you have one of these patients in your office that seems very legitimate, you don't have to have a negative pressure room. You get them in a room by themselves, put a mask on. If you think they need to be tested, please call the ER in advance, and some people have been really good about doing that. We have a way to get them in and out of our ER to the negative pressure room without even going through the waiting room. And if you let us know in advance, we can do that. And those are the folks that probably need to be tested. And as far as, is there going to be, more availability of testing in the future? We've got good capacity. I don't think capacity is a limiting factor right now. It's the logistics of how to do the testing safely and get that information out. So in public health, we talk about 2 different things with epidemics. One is called containment, which basically means stop it at the gate. We're not going to stop it at the gate, it's already here. But can we slow it down? And we get into mitigation issues. And the answer to that's yes. And I'm sorry I don't have any audiovisual aids, I'm a little busy lately. But if we could push the epi curve to the right a little bit and have a curve that looks like that, instead of a curve that looks like this, maybe we get 1,000 desperately ill coronavirus patients in Dallas County. I'd rather have them over the next month than over the next week. And I think some of the containment efforts and the mitigation efforts can make that difference. So I don't want people to despair. It's a lot of hard work, a lot of gumshoe epidemiology through contact tracing and yada, yada, yada. It still works. It helped us with SARS. It can help us here. It's not going to stop it, no, but it can still make a difference. And as far as, I'm going to try to maybe talk to Lisa about getting out a list of resources that I didn't really have time to check out. So if you want, where are the studies? JAMA, New England Journal, Lancet, are where the vast majority of the clinical case theories and stuff are coming down. There are a lot of research things that you can get into. CDC and WHO have websites. There's something called livescience.com. It's a website that basically regurgitates all the CDC stuff, but it's in a much nicer form, and it's much easier for patients to read. It's got a lot of FAQs that are really good, so that's one I'd recommend. IDSA has some things that are available, stuff like that. And again, because of the impact of this, open access is happening on a lot of stuff, so you don't have to subscribe to these journals to be able to see this. The really cool website, if you don't want to sleep at night, is the coronavirus.jhu.edu, which is the Johns Hopkins EpiCurve, and some of you may have already looked at that. We've basically got a tally of cases. And it's a very impressive amount of work from their engineering department there that's put that together. It's just phenomenal. And you can click on, well, gee, what's going on in Togo today? And you can find out how many cases they've had, and how many people have recovered, and how many deaths, and on and on. So I guess I want to kind of just stop with a quote from a Nobel lawyer called Josh, his name is Joshua Lederberg. His comment is, it's our wits against their genes. And I think we just have to kind of keep it together and really try to get good information out in this era of 24/7 media coverage, which is not always very reassuring to patients. So anyone with any particular questions or anything I can answer?
they need there for support. Thank you, Bonnie, for a great presentation, and thank you, Ellen. I'm going to try and give a brief discussion and information about what we're doing at HCA, what we're doing at Medical City, and what are the other hospitals in Dallas and Fort Worth doing to prepare for this. And I can tell you that from a corporate standpoint, we've activated our command centers at corporate. We're looking at supplies, obviously. We're also looking at how we transition from stages. The first stage we're in right now, we call stage 1, there's stage 2, and there's stage 3. Stage 1 is no person has been identified to have the COVID-19 in the region. I think we're past that now. I think we've got some presumptive cases that have been identified, most likely. It's not a matter of if, but when, and how fast it spreads. Then you get into stage 2, and there's when a patient's been identified in the region and what protocols we will put in place, and I'll go over those in a second. But right now what we're trying to do, the only weapon that we have other than Bonnie, the only weapon that I have other than Bonnie, is to control and contain the probability that this spreads. And so we put a screening process in the hospital, limited access points into the hospital. Employees and physicians who have badges shouldn't have felt any difference today, other than if you had to go back to your car and get your badge to get in the e-parking garage, which I saw a lot of you had to do. And there should be self-screening. There's a self-screening protocol and a letter that should come out pretty soon to the medical staff about what that means. And that basically means you know that you're not sick and you're able to come to work. If you are sick and you have symptoms, stay home, and take care of it based on the guidelines that are there. Our employees are self-screening as well. How do we know they're self-screening and they know what that means? We've gotten HealthStream education out to all of our employees. And so if they're showing up to work, they're attesting that they are free and clear and able to come to work and not experiencing any symptoms. So at this point, it's all about containing access. We're screening patients that come in the hospital. We're asking them 3 simple questions of whether they have any symptoms, whether they've traveled into one of the areas, and if they trigger for one of these 3 questions that are logical questions that you would ask, and if they say no, they get a sticker that says that they've screened, and they go off into the hospital. If they're an employee, they just show their badge. We do not ask them the questions. If it's a physician, you show your badge. We do not ask your questions. We have not restricted access into the medical office buildings so that we're not restricting your patient flow. We don't want to keep your patients from being able to get to see their physicians. Where we positioned our screeners is at transition points where our medical office buildings, and thank you, Scott Smith, for working with us and your team, where the medical office buildings transition into hospital space, and that's where we're trying to protect the organization. So that's what we are screening for at this point. Anything else, Melissa, that I left out? I think that we are following attempting to follow the CDC guidelines as best that we can. The mask issues, first I've heard that it really doesn't meet the CDC guidelines, so we'll take that back. We were trying to make an effort to protect the screeners who had the highest probability of coming into contact with some of these patients in our ER screeners as well. So I also had the opportunity last week to find out what the rest of the hospitals were doing. Mayor Eric Johnson invited the CEOs for the Dallas hospitals to the City Hall and to their Office of Emergency Management. And so all the Dallas CEOs came, the higher education chancellors came, the ISD heads of education came, the head of DART for public transportation, the DFW International Airport head, heads of social services, so they had the homeless shelters that were there, to talk about what we were doing and how we were preparing for not the if, but when this spreads and how we're going to be prepared. And so I can tell you that all of the hospitals in Dallas are following and doing the exact same thing that we are doing to try and limit access and to try and screen patients and control and protect the hospital and the caregivers. Bonnie's exactly right. We're going to go from containment and trying to contain and prevent the spread to a surge capacity situation where it'll be workforce preservation, supplies, and I can tell you at this point we are well positioned with supplies. Being the fact that we're close to 200 hospitals in HCA, we have a lot of purchasing power, we've got a lot of supplies stocked up. There is a concern about the supply side coming out of China, that is real, but we are taking steps to preserve or to not discard expired PPE. We're not using it, but we're saving it for later in case. We're also working through protocols at corporate, working with our teams to, is it possible to reprocess PPE, personal protective equipment? And so at this stage, we're at containment and protection, but I think we're going to quickly, within the next day or two, go to, and we have started already in our emergency command centers on how we're going to prepare for surge situations from both staffing, where we're cohort patients. We've got that identified in the emergency rooms right now. We've got an area in the hospital that's ICU capacity that has 8 negative pressure rooms, HEPA filters already in place to be able to cohort patients and how we're going to care for them. Under the possibility and probability that our workforce becomes limited and sick, and they self-quarantine themselves, we have the access to resource nursing throughout HCA and health trusts, and so we're in the process of securing those as well. So we're as prepared as we're going to be. I think Bonnie's exactly right. We can contain and curtail the spread of it over time versus happening real quickly. We'll be very fortunate. So I'm happy to answer any.